Hey there. So let's talk about one of the most fundamental parts of being a nurse. You're not just a caregiver, you're really a guardian. And today we're diving into the single most important piece of that role, patient safety. Think of this as your essential playbook, both for when you're on the ward and, of course, for the NCLEX.
And it all really boils down to this one powerful idea. You have to remember, between any potential hazard and your patient, there's you. Your eyes, your assessment, your gut feeling, and your actions, that's what keeps them safe. It's a huge responsibility. So, to really understand why all these safety protocols are so incredibly strict, we need to talk about something with the highest stakes imaginable in healthcare. We're talking about never events. Just think about that for a second. I mean, hospitals are complex, things happen, but what kind of mistake could be so fundamentally wrong, so preventable, that the official stance is, nope, this should never, ever happen? Well, that's a never event. And here's the part that makes everyone snap to attention. If one of these preventable errors occurs, like a patient having a serious fall, the Centers for Medicare and Medicaid Services, that's CMS, will not pay the hospital for the treatment. So this isn't just about good practice, you see. It's a massive financial and legal issue for the whole organization. Okay, so let's jump right into the most common never event. And honestly, the number one safety threat you are going to face every single day on the floor: patient falls. To really prevent falls, you've got to look at risks from two angles. First up, you have intrinsic factors. This is the stuff that's happening inside the patient. Things like their age, maybe they're confused, or they're on meds like diuretics that make them have to rush to the bathroom. Then you've got extrinsic factors. This is all the stuff in the room, the environment. It could be something as simple as bad lighting, a bit of clutter, or even an IV pole that can basically turn into a tripwire for a patient who's already unsteady. So the big question is, how do we get ahead of this? The best way is to be proactive, and we do that with hourly rounding using the 4 Ps. This is so simple but so effective. Every hour, you're checking on pain, potty, position, and possessions. By doing this, you're anticipating what the patient needs before they even think to get up on their own. You're staying one step ahead, and that's what makes all the difference. All right, let's pivot to 2 other really high-risk situations where your patient is incredibly vulnerable and your actions have to be precise and immediate. We're going to talk about seizures and the use of restraints. Okay, when a patient starts having a seizure, your brain might just go into overdrive with a million things you think you should be doing. But you have to quiet all that noise and focus on just 2 priorities. 1, protecting them from getting hurt, and 2, most importantly, protecting their airway. This chart breaks down the critical do's and don'ts. Your absolute number 1 action, your first move, is to get that patient on their side. That's how you protect the airway, cushion their head, move furniture away, but whatever you do, do not try to hold their arms and legs down. You could actually cause a fracture. And the golden rule you probably already know: you never, ever, ever put anything in their mouth. Now, let's talk about restraints. The guiding principle here is simple, and it's totally non-negotiable. They are always the last resort. Before you even think about using them, you have to prove that you've tried everything else first, things like bed alarms, or maybe getting a one-on-one sitter. Now, when restraints are absolutely necessary, the rules are ironclad. You have to have a specific current doctor's order. PRN, or as-needed orders for restraints, not allowed, ever. And for safety, this is a huge one. You must tie the restraint to the bed frame, the part that doesn't move, and never the side rail. The side rail goes up and down, and that can cause a serious injury. And always, always use a quick release knot so you can get them free in an emergency. Okay, let's zoom out a bit. We're moving from a single patient's bedside to a full-blown unit-wide emergency. You see or smell fire. Your training has to take over instantly, and that training is built around a very simple, very effective protocol. Your first response is always, always race, and the order here is absolutely critical. R is for rescue. Before you do anything else, before you pull an alarm, before you look for an extinguisher, your first job is to get anyone who is in immediate danger out of there. Then you activate the alarm, confine the fire by shutting doors, and only then do you try to extinguish or evacuate. And if you do get to that E for extinguish, you use the pass mnemonic. It's pretty straightforward. Pull the pin, aim at the base of the fire, not the flames. This is key. You've got to kill the fuel source. Then you squeeze the handle and sweep from side to side.
All right, let's bring it all home. We've covered a lot, so here is your final safety playbook. This is the high-yield summary, the stuff you absolutely have to know cold for your exam. So let's lock in these key takeaways. If there's a fire, think race. And remember that rescue is always, always first. If you're using an extinguisher, think pass and aim at the base. And if your patient is having a seizure, your number one priority is to protect that airway by turning them to their side. These are the core actions that save lives. And that brings us to one last little scenario to make sure this is all locked in. A fire starts in a wastebasket. Right next to it, there's a confused patient sitting in a chair. What is your absolute first priority action? The answer is hiding in plain sight right inside that race protocol we just covered. Think about it. Thanks for tuning in.